Hello, everyone. Welcome. We will get started in a few minutes. And in the meantime, we'd love to hear who's on the call. So in the chat, please introduce yourself. Please put your name, your org, your title, and your favorite thing to do in the summer. So here's mine, Shannon Arvizu, Director of Counties Rise, UC Berkeley, and I love outdoor movies in the park. I love yours, Jessica. I love hosting summer webinars. Yes. That's a good
I
one.
hope we have at least one person who says, my favorite is attending summer webinars.
Yes. Thank you, Danielle. Great to have you. Also appreciate camping and being on a boat. Walks in the evening are very lovely in the summertime. Lap swimming, that's a good one. Someone did take you up on the attending summer webinars. Floating down the American River. Sounds great. Couple folks enjoy hiking, running with dogs, family barbecues. Welcome for those who just joined. We invite you to introduce yourself in the chat, your name, your org, your title, and favorite thing to do in the summertime. Nice. It's great to read all of these really fun things in the chat. And also, it's great to have representation from a lot of key folks across the state. I enjoy pretending that I'm going to take a vacation. That is a good one. All right, we'll get started in another 30 seconds here. Oh, got a Dodger fan. Okay. Well, please continue to introduce yourself. We are going to get started here. So welcome to Unlocking the Power of Data Integration to Improve Medi-Cal Delivery. This is the first webinar of our three-part series, and I will pass it on over to our partner, Jessica Sankas, to welcome you all.
Hi, good morning. Thank you very much. I am so happy to see such a diverse group of folks on this webinar this morning. We have folks from local government, state government, folks from the academic community. I'm really grateful for the opportunity to have this dialogue across sectors, really important issue. So I am Jessica Sankas. I'm the Principal Fiscal and Policy Analyst with the California State Association of Counties. Our acronym is CSAC. For those of you who are not familiar with us, we are an association that represents all 58 California counties. Before the state government, the federal government, we advocate for the best interests of local governments, and we provide education about the important work that county governments do every day for the residents of California. We have partnered with UC Berkeley and the Goldman School this summer for a series of projects related to Medi-Cal and the state of healthcare in California, which will be described a little bit more in a few minutes. So this is the first webinar of a series of three that we'll be hosting within the next month or so. I'm going to put my email address in the chat if anyone would like to contact me or learn more about CSAC. And just very grateful for you all being here today. Thank you.
All right, thank you, Jessica. So a little intro to our county's RISE project. RISE stands for Research Initiative and Service Essentials. My name is Dr. Shannon Arvizu. I'm the project director and trained as a sociologist, also just served over the last 3 years as a senior advisor to the White House chief data scientist. And I'm excited to share a little bit about this county's Rise for Medi-Cal project. So we designed this as a 12-week technical assistant effort to help county level stakeholders monitor and respond to policy changes. And we have three goals of this project. One is to capture the policy landscape and to see what might be the county level impacts to populations and health systems. Two, to convey this information in plain language and an easy to share format. And then three, to really build these snapshots that I'm going to share a little bit about in just a minute with county stakeholders, not only to make sure the data is accurate, but that it's helpful for your communication and your advocacy efforts. And so our main deliverable are Medi-Cal policy snapshots for counties. And each deliverable or each snapshot includes a current state of Medi-Cal in the county, a profile of Medi-Cal enrollees in the county, as well as an explainer of how Medi-Cal is managed. And then we go deeper into the 2025 policy changes, both at the federal and the state level. And then we also look at population impacts and the health system impacts, what hospitals might be impacted, what clinics might be impacted, and then to the best that we know, what might be some of the economic impacts. And so as I mentioned, this is a 12-week project. We are now in the home stretch. And so we're reaching out to county governments to share your draft of the snapshot, get your thoughts, interview you on what you find useful, what would you like more of, less of, and then this three-part webinar series as well. So this is part one of that series. So with that, introducing the main topic of today. And I'm excited that we have Dr. Joanna Leco that's with us on the call today. And she's a policy scholar with expertise in criminal and juvenile justice, education, employment, and housing. She's also the research director at the California Policy Lab. And her research frequently connects siloed policy areas in order to better support vulnerable Californians. And before she speaks, I will ask Jessica, who will be our Q&A concierge today, to share a little bit about how you can interact and dialogue during the session.
Thank you. Yes, I am very excited to hear everyone's questions that you have. So there is a Q&A function for this webinar. So please input your questions into the Q&A function throughout the session today. We'll answer as many questions live as we can, sort of near the end of the presentation, but please input your questions in real time as they occur to you. You can upvote other people's questions if you have the same questions so that we know what people are interested in hearing about most. And I will try and provide written responses to some questions as well as appropriate. There are some questions that you may ask today for which I will have to provide a follow-up after this session. And I'll let you know if that happens and get your email address so that we can make sure to get everyone's questions answered, whether or not it's live or afterwards. And you can also, if you have a technical question, if you're having trouble hearing someone talking, anything like that, you can also send me a direct message in the chat as well.
All right. And with that, we will pass that on over to Dr. Leco.
Great. All right. Thanks so much for having me here today. Again, I'm Joanna Leco. I'm from the California Policy Lab at UC Berkeley, and I'm here to talk about the benefits of integrated data and give you some concrete examples from two counties that we've worked with, San Francisco and Sonoma. So again, I'm just going to give you a quick intro into what the California Policy Lab is so you know what we do, describe the policy problem, and then jump into these specific examples. So at the California Policy Lab, we generate research insights for government impact, and how we do this is to partner directly with state and local agencies throughout the state of California to do research that helps inform their policy, decision-making, both internal and external. We work across multiple policy areas, and I think the work that I'm going to talk to you all about today, which is about data integration and high utilization of county services, really is a great example of how we cross we do research that crosses many of these different policy areas. And I think for those of you who are working in counties and working directly with people, you know that these policy areas are really linked together, and that to figure out solutions to them, we have to be thinking about most of them at the same time. So what is the problem of high utilization? Counties across California have reported that a large number of government programs and services are used by relatively small groups of people in their counties. And these small groups of people cycle in and out of hospitals, homeless shelters, behavioral health programs, and jails. They're known to these separate systems and are using those services, having contact with those systems frequently. And this cycling is really evidence that the individual systems may not be that effective at serving this small subset of individuals who have multiple service needs. That each system by itself can't address the multitude of needs that those individuals have. Yet we found that coordination across agencies is pretty rare, mostly because staff have little visibility into the other needs of the clients that they serve and whether or not they're enrolled in other programs. And there aren't many strategies to help clients with overlapping needs. And that's at the client level. And then at the broader level, without coordination and data sharing between agencies don't have a lot of insight into kind of the holistic impact of their programs and policies on people's lives. How are, a criminal justice reform or intervention affecting people's employment or health outcomes, for instance? So the first example I'm going to talk about is in Sonoma County. Our partners in Sonoma were some of the first partners that we had at CPL when we got started. It's been a really interesting partnership and really driven by the county itself. And the county really came together and wanted to think about ways to better coordinate the services that they were providing to people. The California Policy Lab came in to play a specific role in that effort, but it was really driven by the county itself. CPL came in to clean, standardize, and link anonymized data from 6 county and state agencies. So the data were anonymized by the county itself before it was shared with us. Then we identified the highest utilizers of multiple systems in Sonoma County. So we tried to identify that small group of people who are utilizing most of the county's services. We characterized that group's service utilization and their needs and really tried to describe them in rich detail. And we also developed internal dashboards for agency staff to kind of aid in the triage and care coordination of people who fit those profiles. We also, and I'll talk about this in a minute, gave the county back a list that they could then re-identify of people for whom increased coordination of care would likely benefit them. So this is what the Access Sonoma Integrated Data System looked like. This is, there's a lot going on in this figure, but you can see that there is data from the Department of Health Services on mental health services and substance use services, data from the Community Development Commission, and this was housing information, housing service information. The Human Services Department had information from all of the welfare programs, from probation, the Department of Probation on who's on active supervision, and then from the county's integrated justice system on jail bookings, cases, and sentencing. And then from the state level, we got information on hospitalizations, emergency department use, and ambulatory surgery. This was all brought together, linked together, and then we have a de-identified version of these data. And our role was really to use these data to unlock insights about clients who were shared among these multiple systems, understand prototypical use of services, cost patterns, the pathways into and out of this high utilization status, to identify potential service gaps, and then to help design and evaluate potential interventions to address them. So first off, we defined high utilization as being a person whose combined utilization across all of the systems we observed in the data was in the top 1% in a given year. So we worked with the county to integrate data on approximately 425,000 individuals. And these are people who had at least one county service contact between the fiscal years of 2014 through 2018. And this resulted in identifying more than 6,000 individuals who were in that top 1% of utilizers of Sonoma County services for at least 1 year between that period. The font on this is a little bit small, but I think some key points here when you're comparing those 2 rows of information on the high utilizer group with the entire study population is that almost all people we identified as high utilizers of multiple county systems were enrolled in public assistance programs, 99% of them. This is predominantly Medi-Cal. And 2/3 used hospital services during that time, and 2/3 had contact with the criminal justice system. So really high, as per the definition, high utilization of many of these domains of services. When you look at the entire study population, you'll note that only 25% of the entire population received services from more than one domain. So there are a lot of people accessing services in Sonoma County. Most people just access one. But when we focus on this group of people with high utilization, they really look quite different than the general study population or the general county population. And here are just a few key takeaways. So when we looked at this group of high utilizers of services, each year they had 57 days in subsidized stays, and you can see that broken out in the figure. That's days jailed, days in shelter, days on probation, days in the hospital, and days in substance use inpatient care. Over $27,000 in services used, 52% of all shelter and housing for the homeless, and over 25% of jail beds and behavioral health costs. So really significant level of usage. So what happened with this information? We identified these high utilizers in multiple systems. Some of these people had 4 or 5 caseworkers from different systems working independently at that time. The county then used the list that we created to coordinate care through a centralized unit called the Interdepartmental Multidisciplinary Team. And over time, they focused on different cohorts of individuals, but when they focused on the ER cohort, those who had intensive emergency room visits, they were able to reduce ER costs by 32% through this coordination. And another kind of impact of the work was that voters in Sonoma County passed Measure O in 2020 following the report, ensuring that a steady and reliable source of funding would be available to address mental health and homelessness in the county, and that funding would be available for the next 10 years. So next, I'll talk about San Francisco, our work with San Francisco City and County. The goals of the SF partnership developed over time. We started working to support their pretrial working group with data and analysis regarding the implementation of a risk assessment tool in the criminal justice space. And that included our district attorney, sheriff, pretrial services, and probation departments. We also provide technical assistance to San Francisco to meet its goals of safely reducing the jail population through the Safety and Justice Consortium funded by the MacArthur Foundation. And that's been a multi-year effort. We also then collaborated with the San Francisco Department of Public Health and our partners at UCSF to incorporate data from the Department of Public Health, their coordinated case management system data. And this is information on urgent emergent care usage. We linked that to all the criminal justice data that we had been using, and with the express goal of studying high utilization within San Francisco. And some of the benefits of having these data linked together is that we've been able to do quick turnaround analytic work for the county and longer term research questions. including looking right before the care court legislation came out, we were able to estimate how many people in San Francisco County might be eligible for care court. And we also did a deeper analysis of the use of electronic monitoring in the county. Those are just some examples of work that we've done as a result of these cross-system data. So for our high utilization report, we used information from the criminal justice system, that's from the sheriff's office, jail bookings, and from the district attorney's office on charges filed. We defined high utilization within this system as individuals who were in the top 5% of jail bookings in a given fiscal year. So that was more than 3 bookings in a year in our data. And we also used linked Department of Public Health data from the Coordinated Case Management System. That's on diagnoses and services received for individuals who receive urgent emergent care in the county. That can be emergency department visits, psychiatric ED visits, detox, psychiatric inpatient stays, sobering center visits, a bunch of different services. And we defined high utilization as individuals who are in the top 5% of service use for a given fiscal year. And in this system, that meant more than 8 service contacts in a year. So using these definitions, we observed first over 278,000 people with contact with at least one of these systems in our data, over 30,000 who had contact with both systems. And then of the total, 15% had contact, so that's 15% had contact with both systems, and only 5% were high utilizers of at least one system in a given year. And less than 1% were high utilizers of both systems in the same year. So it's really a small number. And then we also identified a category of persistent high utilizers, and those were people who we observed as having high utilization of services in multiple years in the data. This was data from the fiscal year 2010-11 through fiscal year 2019-2020, so right before the pandemic. And I'll take a minute to explain this graph. This is one of the things that I think is so powerful about these data and being able to look at the same individuals and their service contacts over time. So here we look at 10 years of trends for the 211 individuals who had high utilization of both the criminal justice and urgent emergent care systems in fiscal year 2010-2011. So that's the first year of our data. And what you can see is that after 1 year of high utilization, this cohort were very much still known to both systems over the following 10 years. So for instance, 24% still had dual system high utilization. So we're both high utilizers of both systems in the next year, in fiscal year 12. And 40% were still observed in the data and had contact with at least one system in the last year of our data, of fiscal year 2019-20. We also find a startlingly high death rate among this cohort. That's the dark blue bar at the bottom of the graph, with over 1/4 of the 211 individuals we identified were being deceased by the end of the fiscal year 2019-20. And we're actually quite confident that this is an undercount based on the limitations of the urgent emergent care database on death certificates. And in future work, we're bringing in statewide mortality data to improve the accuracy of that information. You can see that this cohort, 80% were male, and the average age in the year of high utilization was 42 years old. When we look at some additional dimensions of need, we found that in the year of high utilization, that first year, 59% of people had experienced homelessness in that year. And again, homelessness status was not one of the characteristics that we took into account when defining high utilization. So it just happens that among these 211 people, almost 60% had experienced homelessness in that year. And that of those we continue to observe in the data over the next 10 years, we see the rate having experienced homelessness in the subsequent years hovering around 50%. We're also able to examine the types of diagnoses people receive from the urgent emergent care system. And we see that over half had diagnoses for all three types, that's substance use disorder, mental health disorders, and physical health disorders in the same year. So high rates of comorbidity among this high utilizer population. Okay, so in this report, we also looked at the most recent year of our data, that fiscal year 2019-20, and looked at individuals who had high utilization of both systems in that year, and then looked back and said, what can we observe about these people over the prior 10 years, and how can that inform services going forward? So here we present the kind of 10 years prior to the year of high utilization for the 161 individuals who we identified as having high utilization in that last year in our data. And what you can see here is that before their year of high utilization, this cohort was largely known to both systems in the county over the course of 10 years. So 42% touched at least one system in the very first year of our data. So these people are having regular contacts with our system, even leading up to the point where they have a year of high utilization. This group was 87% male, and the average age was 33 years old. When we look at those additional dimensions of need, we found that 70% had experienced homelessness at some point during fiscal year 2019-20, the year of high utilization. But among those we observed in the data, the rates of homelessness were quite high in the years leading up to the year of high utilization. And similarly to the first cohort, we saw that half had high rates of comorbidity, had all three diagnosis types in the same year. So some of the key takeaways are that in dual system high utilization in a single year is pretty rare. Again, these are small numbers of people for a large county. But we do find that high utilization is linked to high rates of homelessness, substance use, and death. Both cohorts had high rates of comorbidity, have all three of those diagnoses at the same time, with many also having mental and physical illnesses. Many of these people were known to either system before and after a year of high utilization, although it's true a substantial percentage drop from the data, and we don't know if that's because they move or because they remain in the city or county, but just no longer require services. And I didn't show specific information about contact with the justice system, but almost all of the people that we identified as having high utilization had been booked for a felony and for a misdemeanor and spent many days in jail. Some next steps on this work in San Francisco. We are now adding data from the Department of Homelessness and Supportive Housing, so housing data, to the linkage, which will give us much more nuanced and deeper insight into people who are coming into contact with just the housing system. And we are also, we've received data from the state on mortality so that we can provide more accurate counts in our data going forward. So I'm sure there'll be questions from folks in the room, but just some things to think about how to build a cross-system database in your county. What we found to be helpful are having a coalition of willing data partners. If agencies really see the value in sharing data and being able to access information from other agencies in the county, that takes you a long way in making this happen. There needs to be political will. There also needs to be agency capacity to generate regular data extracts that are of good quality, that allow for good linkages, that allow you to see the type of metrics that you'd like to see across systems. And then you need either a government or a non-government partner to link and securely house the data and conduct analyses. Some other things we've done are create dashboards to give back to counties for them to access, or to give county agencies access, staff access to a de-identified linked data set for their own analyses. So those are some ideas about how these data can be used in a more broad way. So I hope this was helpful. I'm happy to answer any follow-up questions either now or via email if you'd like to get in touch. Thanks very much.
Excellent. Thank you so much. Fantastic. And I can tell that you are a real professional and expert because I can hear the use of data as a plural noun. And that's an excellent reminder for me. My public affairs manager and my copy editors would be very glad to know that I've been reminded of that. Thank you so much for your presentation. And I think we do have one question about whether or not the slides are going to be available to folks afterwards. I'm assuming that you're comfortable with that. Excellent. All right. We're recording anyway, so we'll have a recording available and I can share the presentation with webinar attendees after this. So thank you for that question. The two questions that I see first that I'd like to ask you about are related specifically to the Sonoma County data. How were data sets linked across data sources if they were anonymized? Did the county give the same anonymized ID across data sources?
Yes, exactly. The county went through a lot of efforts on their end to kind of harmonize the identifiers and to assign individual people a unique ID that wasn't related to any of their actual information. So we see a kind of a unique ID for each individual, but we wouldn't be able to re-identify anybody with it. And that allows us to do the linkage across the data systems. In San Francisco, we did that process ourselves. So we did the linkage and then de-identified the data set for analysis. So it can be done either way.
Excellent, thank you. In that same vein, is the Access integrated data from Sonoma County shared with managed care plans?
That I don't know. That's a good question. I'm not sure about that. We do, we have hosted the Sonoma County data for other researchers, so it's definitely possible for other folks to get access to the data if the county agencies agree to the use of it. But I'm not sure about that. That's a good question.
Okay, thank you for that. Next question. I believe this was about San Francisco County. Was the reduction of 30% in ER costs just for the high utilizers or ER costs for the whole county?
I think it was related to just that high utilization group.
Got it. And then I believe this question is from Kings County. What opportunities are there for counties to collaborate with your team beyond the profiles akin to that of San Francisco and Sonoma?
To collaborate with the California Policy Lab team. We'd love to talk to you if you are interested in doing research. So feel free to reach out. We work with a bunch of different counties throughout the state. These are the two data sets that I think are most developed in terms of linkage across multiple systems. That and Los Angeles has great linked data as well. So happy to talk to you about what's possible in your county. And the other thing we try to do is connect state and local agencies with faculty and researchers across the UC system. So depending on where you are and what UC is close to you, there might be a good partner nearby who we could help facilitate a connection to.
Thank you. And Alex, I hope that answers your question. Please let me know if there was something else that you meant by that. Please feel free to add a clarifying question. All right. Here's a question about the term lower contact with systems. So what is considered lower contact with systems? Would it mean that they're no longer in the top 1% of utilizers, or did they just experience some sort of decrease in utilization? That is an excellent clarifying question.
Yeah, exactly. So we measured high utilization kind of consistently across all of the years. So if people had been kind of had high utilization in one year, and then we saw them still getting services, but at a less intensive level, we said that we see them still getting those services, but they're not in that top percentage. And we have reports for both of these counties that we can send out when we send out the slides that go into a lot more detail. But there's some service contacts that might be good, right? That are, we want to see people having frequent, if they're getting mental health services that are preventative or behavioral health services, physical health services that are preventative, we want to be seeing those. So I think there's more nuance than just saying, high or low and connecting that to good and bad. But we tried to really calibrate it so that people who had high utilization, that was kind of a signal of distress and a signal of things not going well.
I see. And going to go a little out of order with the questions because there's another question about utilization. What data did you use for San Francisco County to identify high utilizers who experienced homelessness during the year? And how
Yeah.
is that different from the homelessness data you anticipate using for future data linkages? That's a long question, so let me know
No,
if you
that's a
want me
great
to read it again.
question.
Okay.
So we were limited in our initial study to only observe housing and homelessness status for people who had contact with the urgent emergent care system. So you had to have contact with that urgent emergent care system to be asked if you were experiencing homelessness or not, or what your housing situation is. There's a lot of options. If you didn't have contact with CCMS in a given year, we wouldn't have observed your housing status for that year. We knew that was a big gap in that report, which is why we worked over several years to bring HSH, Department of Homelessness and Supportive Housing, into the linkage. That will do a lot of things. It will allow us to get much better information on housing status and much more frequent information on housing status and housing services received for people in the county. And it will also allow us to see the intersection of people with just criminal justice contact and housing service contact, but no urgent emergent care system. Right now, they're not kind of highlighted in our analyses. So we'll be able to do much more with those data.
Thank you. All right. Next question. Did San Francisco or Sonoma County develop any data gathering tools so data can be gathered by the various systems quickly and comprehensively?
That's a good question. I think all of the data that we used for these analyses were administratively collected data. They weren't designed for either study in and of themselves. That said, I do think, at least in Sonoma, they've thought a lot about how to streamline how they kind of intake people, particularly into housing services, in order to kind of get the information that they need more quickly and make decisions more quickly. So I do think some of this work has informed how they collect data now, but I don't think any new data collection tools were used that I know of.
Got it. Next question. Do you plan to do any causal inference work with this linked data?
Yeah, I assume you mean causal inference, and we have done several causal studies with the data. An example would be in San Francisco. We conducted a study looking at the impact of felony diversion programs on subsequent criminal justice contact that used, for those of you who are interested, kind of the random assignment of felony cases to judges who had a different probability of diversion. That study is out, and now one of the big questions that was left by that study, it's great, these diversion programs are really interested in addressing the kind of underlying needs that people have when they become involved in the criminal justice system, mental health needs, drug treatment needs. But the study didn't give us any insight into whether people were getting the services to address those underlying needs. So now we're doing a follow-up study, very similar impact study, looking at the impact of felony diversion on health, housing, and mortality to try to get at specifically those questions. So I do think many of the partners are interested in expanding the set of outcomes that we consider when we're doing an impact study, to look beyond those that are just observable within their system, and to look more broadly and tell that bigger story of what the impact of a program or a policy is.
Thank you. So the next two questions are related to broadly behavioral health. So did you look at all into clients who had no contact with the specialty behavioral health system?
Um, I'm not sure in which study you're referring. No, in San Francisco, I'll say there is a lot of detail about the services that people have received. There's more detail in the report than I presented here, but we don't get down into the real kind of fine detail about the specific types of services um, people are receiving, or people with a specific diagnosis are receiving. That's definitely possible in the San Francisco data. The data are at the event level, so we actually see each contact individually that each individual has with the service system, date, type of service, even at times a cost associated to it. So there is a lot more that can be done in that realm than we have done.
Mm-hmm. Thank you. Thank you for that. And again, for this question, if there's a clarifying or a follow-up question about specialty behavioral health, please put that in the chat or in the Q&A function, or we can try and get back to you with more information about that as well. So next question is about the three diagnoses correlated with high use. And the question is, are they the same as the ones identified by the CARE Act or CARE Court, as I think some folks commonly refer to it? So I'm not sure how familiar you are with the CARE Act.
Yeah, I would have to look to see if they are completely aligned, but we did use the Elixhauser comorbidity index, I believe it's called, to define the categories that we used, and there is more information about that in the report. So hopefully they are the standard ones. That's what we were aiming for.
Okay, so I will definitely flag that one as one to follow up on. And broad question, what challenges did your team have during data collection and analysis? And can you share any challenges that you know of that the county staff may have experienced?
Sure. There are a lot of challenges. First, in setting something like this up, it can take a long time to get data use agreements in place initially, to make sure everyone's comfortable with the data sharing, and all of the legal boxes are checked. We have a lot of experience doing that now, so hopefully we can try to expedite that process for people who want to share data with each other. But that DUAs can take a long time, just on both ends, on our end, and on the county's ends too, depending particularly on how many agencies are involved and need to be signatories. And then I think, all of this work is doing data analysis and research with data that were not collected for the purpose of research, right? They're data that are collected for case management and for tracking clients and for whole different purposes. That's what administrative data is. So there's always a data wrangling, data extraction process that needs to be figured out the first time that it's done. And it's using data in a way it generally hasn't been used before. So there can be a learning curve there, for sure. And what we always encourage counties to do is to document really, really well what, exactly the code that was used to make a data pull so it can be reused in a subsequent year, and things like that. But that, data systems change, that's a big challenge. If, the Department of Public Health in San Francisco used to use CCMS and now they use Epic, and that change has been challenging for I think for everyone, but also for research. And there are examples of that in both counties across multiple systems. That's just how things work. So I think those are some of the main challenges that we've come across. I think everybody we've worked with, we have great partners. I mean, all these county agencies are so wonderful, and they really want information and they want the insight. So I think the will is there. Sometimes it's just the capacity, and just finding time in the day to do this kind of work versus all of the kind of really pressing things that come up. We worked with both of these counties through the pandemic, right, when many of the staff were reassigned to other purposes even, and like extracting data maybe wasn't the top priority. So I think, we want to do research and conduct analyses that counties value and that they need. Otherwise, there's no point in us doing it. So we tend to just have regular ongoing conversations with all of our data partners, and that helps really surface the things that they are working on and stressed about at a given moment, and we try to then respond and say, figure out ways that we can help or adjust timelines however we can.
Thank you. That very thorough answer. Maybe I missed that at the beginning, but yeah, during the pandemic, that is, yeah, a challenging time to try and, on top of everything else, do a project like this. That is an excellent piece of context. So one of our last questions, more of a comment, save this one for the last, but I think there may be a question in here somewhere. So I'm not sure how prepared you are to comment on the Cal AIM initiative in general, but maybe we'll follow up with this one afterwards. But the comment is, with regard to the problem of high utilizers, I had the understanding that the state creation of Cal AIM and ECM, Enhanced Care Management, was intended to help address this problem, just one major tool.
I totally agree. I think everyone we talk to is excited about the potential of CalAIM. Many of our agency partners are just trying to, especially on the criminal justice side, are trying to just figure out the billing, how it works, and doing all the like really detailed planning that's required for implementation. But I agree, it has the potential to be really transformational for the system. We're interested in studying the effects of CalAIM and the implementation and impacts of it, and as are, I'm sure, many researchers. And just, really curious to see how it goes when it's really rolled out. So yeah, I think it's a great point.
And one last question that just came in that I just saw about the client studied and did they sign an ROI consenting to this data sharing?
I can't speak to the data, the process that every single agency went through when they were collecting data for the services that they were providing to people, because I'm sure it varied.
I was
But
going to say, it might be more of when I read it, might be more of a question for the counties themselves.
right.
Okay, I don't see any other questions. Folks do have my email address in the chat, and you will definitely be able to follow up with us after this session if any other questions occur to you afterwards. I know that happens to me sometimes when I attend a webinar and you're thinking about that information later in the day. Thank you for answering all of these questions. Wonderful presentation, fantastic knowledge, and I will go ahead and turn it back over.
All right. Well, wanted to share the next topic in our webinar series. So next Thursday, we will be talking about navigating the MCO tax and Proposition 35 and what the implications are for California counties. We're excited to have Jason Constantoros from California's Legislative Analyst Office, who will dive deep into this topic with us. So we will send out a registration form shortly after this webinar for those who would like to participate. And thank you again to our presenter today. And we look forward to seeing you all next week. Take care.